I'm from South Africa, from an organization called Global Black Gay Men Connect. And we work in the region and the diaspora on human rights, HIV prevention and treatment, specifically for black gay men. And we're headquartered in South Africa, in Paris, and in Washington, D.C. But I'm not going to talk about me today. We are going to have our speaker, who is going to talk a little bit on innovative financing mechanisms and to explore social enterprises. So we were supposed to have 3 speakers in this session, and I think if you have been attending session this morning, I don't know what is happening, possibly it's because it's the first day. 2 of our speakers couldn't make it today, but I think it will give us an opportunity to ask more questions, to speak amongst ourselves, what can we do on mobilization of resources within this continent. So let me introduce to you Mr. Humphrey Ndondo. He's a public health advisor and worked specifically within this region for the last, I think, 25 years. And I've been knowing him. I've got, a chance to have met him. He has been working for the National AIDS Council in Zimbabwe, a public health practitioner on social justice, gender justice, with more than 20 years championship on sexual and reproductive health, and he will be our speaker today. So a round of applause for him as he comes on the stage. Over to you, Humphrey.
Thank you, Brian, and good afternoon to everyone. So as introduced, my name is Humphrey Ndondo. I am a public health practitioner, and let me hasten to say, a very novice really in this discussion, but a human being and nonetheless one of the people who are affected by the HIV response. And how we get affected is really dependent on how well, on how ill we plan our responses and we fund them. I'm excited that I'm privileged to be speaking where my seniors and superiors from our Ministry of Health and Childcare National AIDS Council are also in this room. And I'm confident that where I misstep, they will be here to hold the mic and correct the discourse so that we have a more nuanced conversation. What we really, really would love to see, not only a discussion about what is happening in Zimbabwe, but some of the solutions and how you see them. How you see them. We are really in an unprecedented time in the time of the HIV response, where we are really required to relook and to rethink how we retailor the response to ensure that no one is left behind. Let me also hasten to say that my perspectives of how I am going to share my presentations today is based on our experiences in programming with communities that live on the margins, that is communities of key and priority populations, so communities of men who have sex with men, communities of sex workers, communities of people who use and inject drugs, and communities of persons in enclosed situations. So sometimes you may discover that you know or you have seen a different experience in the architecture of how the funding is flowing, and we're particularly excited to hear that nuance and how it can be leveraged to benefit the communities that I have listed. As a way of background, really, key populations, as we all know, are at a heightened risk of contracting HIV due to some of the challenges that we all know. They face stigma and discrimination, criminalization and other structural barriers, and that we can reach key populations. It has been proven that if you utilize the differentiated service delivery approaches forecast at these communities. You will be able, we have interesting peer models that we have employed in the past to ensure that we navigate our communities out of, mud and mortar facilities into the communities in what we call hub and spoke hubs, to ensure that we reach each individual at their houses and in areas where they find convenience in receiving their method or choice of intervention for HIV prevention, care, or treatment. We are aware of what has been happening in the space around opposition or pushback to diversity, to equity, to inclusion, that has made even, programs, grapple with challenges reaching these communities or to service these communities. And we are seeing that all these differentiated service delivery projects that we had put together, human-centered design insights to tailor this methodology of approaching them, is now, being seen as a waste of money, is now being seen as preferential, and countries are being dissuaded from using this, which is what we really are grappling with. So these funding gaps, we're seeing all these funding gaps as the donor support declines and the domestic financing remains limited. So we do see a solution certainly in public-private partnerships that they present, and we need to see that this resource mobilization, innovation and service access translates to communities on the margins in real time, in the very same time that we are seeing other communities access it. Currently, we are seeing our countries are excited and doing a great job in the introduction of lenacapavir, and we're seeing the fastest speeds by which countries are able to adapt and have these innovations in country. Our plea and our watchful eyes to ensure that these new innovations arrive with our communities with the same pace. So for again, bisexual men and other men who have sex with men, with the same pace or even better, because these are the communities that we should precisely target to ensure that we are able to reverse or reduce the rates of new HIV infections or to gain public health impact. My only personal fear is that we will have a great lenacapavir program and we do disseminate lenacapavir to people without precision. It will be taken up and we will fail when we model to demonstrate that it has reached the communities that would have benefited from it. That would be a wasteful use of resources, to borrow the language that is currently being used, and ineffective. So it is very important that as we're planning, we're engaging with communities that we knew before the 20th of January 2025 that these are the communities that ought to be targeted by these game-changing interventions. I remember the English I would write to my colleagues, I would look at you. We used to write about game-changing language to ensure that communities that are left behind have access to these services. If we change that language, we are changing a game and responding to a response that we want ourselves, to an epidemic that we want ourselves and not the one that we are contending with in our different countries. So the problem is that we are seeing these persistent funding cuts and that they are limiting the scale and sustainability of the services for KPs. I did not prepare any slides to demonstrate just how much we have lost. But if you know a PEPFAR program, if you have been involved in any form of programming, the programming within PEPFAR in a lot of our countries was developed in conjunction or in complementarity with the Global Fund national effort, right? A grant and the domestic financing bill that is there every other source of funding that could have been coming from other foundations, etc. The division of the level of effort and work to be done per geographical area was also divided to ensure that so-and-so will work from A to D, and from E to X, so-and-so will work, and so-and-so will work in Z. But if we realize that we have removed specific donor X from the service and we reprioritize and we give playing rules that say we are not going to allow anyone to be taking responsibilities from donor A, it means that we are delimiting where people are going to work and if those people in that area have access to services. And we are asking communities where we are closing clinics to go to the nearest, where they have expressed that they have challenges with stigma, with discrimination, with criminalization, with negative attitude, with being treated badly. And we have said that if they are serious, they will go and access services at the facility. But all that we have understood, if we have been developing family planning, if we have been developing condom access, if we have been developing access to PrEP, is that choice is very important and that we should be ensuring that we are reaching people with as much convenience. We also understand that public sector services often lack the flexibility for the specific required needs. And as a country, using Zimbabwe as an example, we had developed standard operating guidelines to ensure that public sector services provide friendly and affirming services. And we're distributing these and training healthcare facilities that we had identified as centers of excellence with intention to bring this to scale. So all this work was halted not only in what we were doing with the trainings, building capacity of healthcare workers, in also ensuring that there is even that technical support that I and my team used to provide at national level and subnational level to escalate and accelerate the provision of services to different key populations across the country. So that's the kind of level of scale of distraction or disturbance that we saw. And the footprint of colleagues that were providing services as what we called enhanced PA models over years, over just a period of 5 years, we had sophisticated, for lack of a better word, let me use this, we had sophisticated this cadre of, you would call a basic or entry grade level kind of support as an enhanced PA mobilizer to be a differentiated service delivery assistant that provided better navigation abilities that could counsel a client with confidence and with comfort, etc., that could navigate a facility for better linkages and support with treatment, and identifying early signs of treatment failure and supporting treatment treatment adherence, and ensuring that that model continues to be supported by KPI astute and KPI identifying officers, professional officers. We had also gone to a position of hiring key population officers who were working within the system to ensure that all this work with the lay cadres and with professional staff is supported and supervised. And all this, when we closed some of the PEPFAR clinics, this was gone without specific referral, but just a note at the gate that says, go to the next clinic. Coordination is one of the things that are really, really big. So, and the reason why I'm talking about all this, and you may think I'm all over, is that when you are talking about what you are funding in DSD, you're funding the human resource, you're funding where the drugs are going to be procured, by whom the drugs are going to be put, and what methodology is going to be provided. So all these things are very important. So ensuring that you have the technical support and the human resource scale to do this program is very important. And one last piece that we have been struggling with a lot of countries, we have done so well with uneven progress is the limited digital integration and innovation that reduce efficiency and reach. So ensuring that people are able to be booked for the next clinic, for viral loads, for follow-ups, etc. A lot of these countries struggle with system downtime, with supply of power, with human resource to ensure that this is happening with fidelity. So in response to these evolving fiscal pressures, one of the things that Zimbabwe has quickly done as a country is that we have developed a minimum package of essential HIV and TB service interventions. And these are tiered across three particular scenarios where we don't have any donor funding. There is an effort to posture activities that should be at the minimum provided to ensure that individuals have a quality of care at the minimum, and then at 50% and at 75%. So sorry, at 0%, 25%, and at 50%. So it's very important to ensure that that particular service delivery model is what we're going to be working with to sustainably manage the withdrawal of external funding from the countries in the south and to stabilize sustainably in a way that governments can consume or absorb the shock that they are currently experiencing and develop these scenarios. This is not without any challenges. We have challenges of equity, particularly for communities that require intensive outreach support, like your sex workers, like MSM, the broader the adolescent girls and young women, women of childbearing age, etc., that require support outside the facility, because you will stop outreach, you will stop some of the essential tenets of HIV prevention in the work that you do, where you completely don't have funding. So you may have to prioritize and say, in this particular instance, we are only going to be able to provide these services. So, and there are principles that are currently being followed in this modeling approach, inspired by WHO and really anchored in country specifics around a person-centered approach. Some of the interventions, so certainly ensuring that we are establishing frameworks linking the government, the private and health sector, and civil society organizations. Zimbabwe has a triple P strategy that it is currently but being reviewed as part of the development of the National Development System 2, the National Development Strategy 2, and the generation of the ZINAS, and the upcoming generation that we're currently reviewing. So these are also embedded in the development of co-financing mechanism infrastructure and the co-sharing modalities. We still have continued with some of the best practice that you have seen. Just last month, we were part of the Global Fund replenishment, participating as a donor in that space and ensuring that there is a cake that comes to the HIV response. Very important to follow and ensure how that works for us. Expand integration and the private clinics into DSD networks, incentivize private sector investment through rebates, through sugar taxes, through food taxes, and through airtime bills. Some of the strategic interventions include integrating digital platforms for appointment systems, virtual counseling, and data reporting, strengthening governments through joint monitoring committees, and clear accountability frameworks, building out your private sector capacity on person-centered care and rights-based service delivery approaches, and facilitating innovative partnership that is in telehealth, in self-care models, in friendly distribution, and ensuring that mobile clinics are getting to where communities are. I had just really pulled some of the indicators because this is one area that we don't measure so well. As someone who has worked with PEPFAR over the years, we still have this thing about indicators and ensuring that it has to be measured for it to be done. So the number of agreements established, supporting, friendly and care, the percentage increase in private sector financial contributions that are able to garner, the number of civil society organizations integrated into Triple P implementation arrangements, the change in service coverage for minority groups. It could be adolescent girls and young women, it could be KP, or it could be children, etc., and uptake of digital health innovations. So I wanted to share and stop there and invite colleagues. So we're supposed to have a full panel of 3 other speakers that we're going to plug all the other gaps, but fairly, yeah, I think we can facilitate a discussion. If there are any difficult questions, like I said earlier on, my superiors are here.
Yeah,
Thank you.
thank you so much. A round of applause for Humphrey. You can come and sit here. I guess we've got some mics around, right? Somewhere who can ask some questions. You know, this is a very important question, and I think I love what Humphrey, how you brought the discussion and in sharing specifically around different, models of service delivery, which was really being primarily financed, by donors. And I think that example resonates with different countries. And I'm going to be sitting down so that I don't speak on top of you. And you mentioned one thing, as people are thinking of their question, you've been involved in the PEPFAR processes, and from my understanding, we started to talk about sustainability at PEPFAR since 2015, and now we are in 2024. Why before the January 20? And thinking about innovative financing, you've mentioned a little bit, especially from the example from Zimbabwe. What have been some plans that were there before the 20th, with your experience from Zimbabwe and with work that you are working within the key populations? If you can, finish us with that, please. Does anyone have another question? Somewhere? What a quiet room. Yes, there's an gentleman with a question, yes?
Sure, thank you so much, and good afternoon. I just want to find out, since the withdrawal of the PEPFAR funding, you did mention that you guys have developed the minimum guidelines in terms of what are the minimum services that you're going to be delivering for both HIV and TB. I want to find out some of the initiatives that you have taken in order to bridge the gap that resulted as part of that particular, funding withdrawal. And just to also find out what kind of modalities, in terms of, because that affected a lot of things, from the NGO perspective, from the human resource perspective, from the financial perspective, and also IT and equipment. What kind of a strategy you guys follow in order to replace that particular gap? That is something that you are struggling with in South Africa in terms of standardizing that particular process. Thank you so much.
Thank you so much. Go ahead, please. 3 questions.
Thank you so much. Forgive me, I have shades on. My eye is not okay. It's no disrespect. My name is Barbara Kemigisa from Uganda, and I'll just love to share something on innovative funding, and I appreciate this panel and your presentations. And this is one thing I have noticed in my few years serving people living with HIV as a person living with HIV. I realized there is so much funding, but as people living with HIV, we literally only get ARVs. Unfortunately, on getting ARVs, we have so many challenges we are battling with, and yet all the time someone is knocking at your door. Have you swallowed your medicine? Why are you not coming to hospital to pick your ARVs? But I've reached a point where you find ARVs is the least of my problems because I have so much going on in my life. So how did we create sustainability for ourselves? We started creating small peer support groups, and these peer support groups, as we are seated talking, we are making tiny, tiny paper beads. And with these paper beads, we make tiny bracelets. So we choose days where we go out to the communities and we sell. I personally go knock on big offices and sell these bracelets. I move with these bracelets to conferences like this. But what have we been able to achieve? We've managed to get some of the young people to regularly go for their medical appointments at the facilities, especially those we picked and had dropped out of care. We have seen improvement in nutrition. We have seen some of the young people who had dropped out of school go back to school and keep in school. But we have also been able to build the first safe space for young people in Hoima. How is this improving livelihood in our communities? It's not just for us, the people living with HIV. We are also doing it for the mothers, where our mothers have now started projects like piggery. So we are saying a lot of funding is out there. But to be honest, it stops in the big organizations, where these organizations are buying Land Cruisers every year. They get 7-figure salaries. They get meetings in big hotels and get per diems, which is really not helping us, but they use our name. So I think these ways are maybe some of the ways, if the domestic funding we are talking about can come down and create sustainability projects for people living with HIV, it may make more impact than funding big organizations and agencies that are going to leave us out. Thank you.
Hello? Yes. Thank you so much for that question. I think it really comes into our minds. Irrespective domestic financing, does it filter down to the real people who need it? The donor funding, was it going to real people who need it? So when you're talking about domestic financing, what is the discussion that happened? And I think this is a very discussion coming from him. So Humphrey, do you want to respond to these questions?
So I think I'll attempt the three questions. I think the first one spoke to, PEFA has been having the sustainability conversation as an entity for since 2020. That's in the past 5 years. Government has been having sustainability conversations for the longest. And I think the biggest challenge was that in our cooperation, or the government's cooperation with different individuals, was the understanding that this sustainability planning and the process of transitioning was something that is going to be planned, transitioned over time, predictable, with all these plans that we're talking about. So this is the tiered approach of when we have money, of when the money has been taken away, etc. But the way it's happened is, like I said, unprecedented. I'm just going to give a bit of an example in terms of context of why I'm saying so. Zimbabwe is one of the